We're going to list the required and additional references as well as resources for dispensing methadone. And we're going to briefly review buprenorphine naloxone dispensing, including the list of references.
Hi, everyone. Thank you for joining me today. My name is Dr. Joel Boardman, and today we're going to take a look at opiate use disorder, and we're going to look at the aberrant drug behaviors that we see from time to time. We're also going to look at the polysubstance use and some psychiatric comorbidities. The first half of the presentation is going to be taking a look at those aberrant drug behaviors and polysubstance use. This is my conflict of interest side. I've done some work with a couple pharmaceutical companies that delve into medications for the addiction field. I also do lots of work with the Ontario College of Family Physicians, the Canadian Medical Protective Association, and I really see where doctors have some weaknesses and get into trouble with prescribing opioids. In this first half, the main objective is I want to take a look at the differential diagnosis of any aberrant drug-taking behaviors or what's happening when people aren't doing well on opiate therapy. We'll also look at some of these other objectives too. The first thing I'd like to do is I'd like to look at a case example. I'm going to call her Jane, a 50-year-old woman, and my main purpose of this is just to get you thinking of people who may be coming into your pharmacy and just some events that happen and how we think and what we think about what might be going on. So let's say you've known Jane for about 6 months. She gets hydromorphone, the long-acting every 12 hours, 12 milligrams, and some immediate release hydromorphone, about 3 a day. And for 6 months, things have gone okay. And she comes in after 3 weeks on her 4 prescription, and she states that she's out of pills. Maybe she wants you to call her doctor or something like that. So I haven't given you a lot of information here, but my main purpose is to just get you thinking of, has this kind of event happened in your pharmacy and what your thought process is. So what I want to ask is, healthcare providers, when we're faced with a difficult clinical scenario, what do we do? And basically what we need to do is form some sort of differential diagnosis. Don't jump to any main conclusion, but I want to take a look at what are some of the possibilities of what could be going on with Jane. So the first thing we think about when someone's maybe come in a week early and needs more of a prescription is maybe Jane's got an addiction to her opioids. Another thing people think about is maybe she's diverting her opioids. Now, I'm going to go through a longer list, but I'm going to talk about these two things first. And the other thing I want to stress with this is all these things that I'm going to talk about, they're not mutually exclusive. We can have a mix of several different things like this. So when we take a look at someone who's prescribed opioids and we're worried about possible opioid use disorder in someone who's being prescribed and getting them from one doctor at one pharmacy, this can be a very difficult diagnosis to make. So this is a DSM-5 criteria. It ends up, based on the next slide I'm going to show you, be it mild, moderate, or severe, causing some sort of clinical impairment or distress. Here's the 11 criteria that we go on. Now, I've highlighted some different colors here because I want you to think about somebody who maybe comes into your pharmacy and they are getting the prescription and they have a pain condition, and let's say they never intended to be on these opiates for this long and are really trying to get down and lower their dose, but their life decompensates every time they get to a lower dose. If we filled out a DSM-5 criteria on somebody like that, those red things may end up being positive. Unsuccessful attempt to cut down. Yes. Neglecting other life activities. Yes, my pain is so bad when I get to a low dose, I can't do things. Using for longer than was intended. Yeah, I never intended to use this long. They might also have developed some tolerance, or they might have a bit of withdrawal if they miss their pills. That person maybe doesn't sound addicted to you, but can still have enough criteria that we put them in that category. So as I say, this is a very tricky diagnosis to make in someone who's actually prescribed the opioids by one doctor and getting them at one pharmacy. Let's take a look at the opposite. That green one I've highlighted, long period spent obtaining drug or recovering. Well, maybe if someone does have an addiction problem, but can very easily get all the opioids they need, and they're not spending a lot of time obtaining the drug, they never have to recover because they have enough of a supply. They'll check off no, but really, that would be an issue. So once again, we have to be cautious with our DSM-5 criteria in somebody who's prescribed opioids. It can be a very difficult diagnosis to make. Here's another definition of addiction by the American Society of Addiction Medicine. And read it out to you. Addiction is a primary chronic neurobiologic disease with genetic, psychosocial, and environmental factors influencing its development and manifestations. And on the next slide, we're going to talk about what some of those manifestations are. Just as an aside, I put chronic in red. I want you to realize that addiction is a chronic long-term illness, just like diabetes, just like hypertension. People can get better, but it's always there and can always recur, relapse. So let's take a look at what some of those manifestations are. So it's characterized by what we'd call the 4 C's: impaired control, compulsive use, continued use despite harm, or cravings. In my experience, when dealing with prescription opioids that are prescribed, the most common one of these that we'd see, number 1, impaired control. And that might be what's happened with Jane. She's in 21 days on a 28-day script. Maybe she had some pain in the middle of the month. Maybe she had some stresses and started overusing her medication. She was unable to control the 60 long-acting pills or the 90 short-acting pills. Now I'm showing a slide of a diagram, and I don't want to go into too much detail on this. My main purpose of showing this picture is to have you remember that when someone has an addiction to opioids or an opioid use disorder, there are brain changes that happen. Basically, there's this superhighway of dopamine, and it hijacks what we would normally need dopamine for, and everything becomes centered on getting that drug and using that drug. Again, I don't want to go into too much detail, but I do want you to remember after the presentation today, oh yeah, when I see somebody with an addiction problem, there are some brain changes that are happening in that human being's brain. Okay, so we've talked about addiction. Now I want to talk about diversion. And let's take a look at who diverts their opioids. Now, the smaller the town that you practice in, the easier my example might be to comprehend. The comfortable way to think about diversion is, let's say there's a shady bar at the end of Main Street, and there's guys who come into that bar from another town, and they sit at the back, and they're selling pills to our young people or some of our vulnerable people in the population. And boy, we need to close down that bar. We need to get rid of those guys because they're ruining things in our town. That's the comfortable way to think about who diverts their opioids. But now if we take a look at this slide with the pie-shaped graph, we see that over half of the diverted opioids were given by friends and family or relatives for free. And that's a little less comfortable for us to think about, but I think it's important as healthcare providers to realize that that's what's going on. People are sharing their opioids. Someone's got some Percocets in their cupboard, and their spouse or friend, hurts their ankle, and it's like, oh, I've got something here. Why don't you try some of these? Or an elderly relative who, because they had, some painful conditions or a cancer and they're 82 years old, they get lots of opioids, and maybe the grandson needs opioids or the daughter, things like that, and there's some pressure to divert there. So we need to recall and remember that a lot of diversion of opioids is friends and family for free. That could be what's happening with Jane. So I took a look at those categories. Now I'm going to take a look at another category in our differential diagnosis, categorize in what's going on at the actual opioid receptor. So the first thing is something called opioid-induced hyperalgesia. And what that is some sort of paradoxical response where instead of the opioids relieving pain, they actually cause hyperalgesia, more pain. And what do we do when people have more pain? We give a higher dose. What happens when they get the higher dose? They end up getting more pain. And I see this especially in people that are on higher dose opioid therapy, especially on some long-acting medication that is not working as long as it used to be. So we took a look at opioid-induced hyperalgesia. There are a couple other things. What about opioid unresponsiveness? Not everybody responds to every medication. Now, we do know that with codeine, at least 10% of the population does not convert codeine to its active form of morphine. But I'm sure there are other medications that people just don't respond to. What about another thing that I call withdrawal-mediated pain? Once these opioids that were advertised as working 12 hours stop working 12 hours and only work 10 hours, 8 hours, 6 hours, a lot of times the main area that you had pain in, as the pills are wearing off, as withdrawal is starting, that's when you start to get that pain again. So a lot of times people are just chasing that pain that's always recurring now. So one term that I'd like to try and avoid using in 2020, and this slide first said term to avoid using in 2015, and every year I change it, is the term pseudo-addiction. Pseudo-addiction was meant to mean that if someone has pain and has behaviors that are consistent with addiction, all that means is that they are doing this because they have pain, and we need to give them more opioids to get them out of pain to stop them behaving like this. Well, there certainly may be some avenue to accept this in some patients. My personal belief is this has done a lot of harm, where we've ramped up a lot of doses in some vulnerable patients who were developing an opioid use disorder and made it worse. I think the best thing to do in 2020 is if someone is starting to display signs and symptoms of an opioid use disorder, the kindest thing we can do for them is accept this and help steer them towards buprenorphine or methadone if that's going to treat their opioid disorder. So we've taken a look at addiction and diversion. We've now taken a look at some terms that we use for kind of what's going on at the opioid receptor. Now let's look at another category of everything that we can put in the psychological issues. So the first one I'd like to look at is some sort of organic brain pathology. We have a lot of people on benzos. People are getting confused. Jane's 50 years old. What if Jane was 80 and developing a little bit of dementia and just knows that she has these pills? They're not in dosettes. She gets confused, she has pain, she takes another pill, she has absolutely no idea when she took her last pill. And you can see very easily where people can start to run into problems with overuse from confusion or, having some issues around that. And again, especially in the benzo categories too. What about personality disorders? And I'm going to talk a little bit more about personality disorders later in the talk, but especially that cluster B, the narcissistic, histrionic, borderline, where there's a sense of entitlement or impulsive behavior. These people are probably prone to have some sort of boundary issues with a treatment agreement that might be signed, and that can lead to some conflict within the medical office and the pharmacy. There's also a term called chemical coping. We live in a chemical coping society, and a lot of people might just be on the border of being appropriately taking their medications. Another term a doctor mentioned to me was a patient seems like they're a reliefaholic. They just always turn to a pill and feel that for whatever ails them, there's something that they can take. This is a cartoon, and if the writing's a bit small, it says, ask your doctor if taking a pill to solve all your problems is right for you. And again, I think that fits into a chemical coping society that we live in. And lastly, and I've put this in red, bigger font, is a lot of times people are self-medicating for some uncontrolled depression, anxiety, post-traumatic stress disorder. And I'm going to talk about a chicken egg phenomenon of people who overuse their medications and have mental health issues, but I find this is a very common thing within my practice. So that kind of sums up all the different things. Let's keep in mind that these things are not mutually exclusive. And later we're going to kind of take a look, well, what could be going on with somebody like Jane? There's many things that could be happening. And we'll have some similar examples and what to do. Now, here's just a little something about how to detect some unauthorized substance use. And my own personal bias is that as we do a lot more telemedicine, I understand the benefits of that, but we're losing that human-to-human contact I know for a lot of physicians. And I learn a lot from just directly observing and smelling a patient and seeing their body language, not just their face that would be on a screen. I learn a lot from walking with them down the hall into my room, how steady they're walking. And I think we lose a lot of that. And in a pharmacy, you all have the advantage of seeing them on a day-to-day basis. And, do they smell of alcohol? Are they unsteady? So, I love when people report to me that there are issues that I might not pick up on. And there's urine testing that we can do to detect that and to detect unauthorized drug use, be it a dipstick of an immunoassay or chromatography that we would send to the lab. What are some concurrent substances that people misuse? Let's always remember the most common thing is tobacco, that, not illegal, certainly causes health issues. And I'm going to take a look at some of these other ones on the list as well. Now, for the urine tests, the point of care urine tests, they're done by immunoassay, and they usually test a few simple things, benzos, methadone metabolite, opioids. And the opiates that we're testing for are derived from the natural resources. Those are the easy ones, morphine, codeine, heroin. But if you look at the bottom there, oxycodone and fentanyl will not show up as an opiate unless we specifically request them. And remember, I do a lot of work with the CMPA, the Doctors Protective Association. I see that, a lot of times doctors are doing urine tests and might not fully understand some of the nuances of what shows and what doesn't show. One thing I will point out to you, a very unforgiving drug on a urine test is diazepam. One 5 milligram diazepam in somebody probably lasts over 3 weeks in their urine test. Just an important thing to know that if they are going to take it and it's going to interfere with a urine test, they should know that that'll stay for 3 weeks and can cause some issues. Let's take a look at a case. We'll call him Bob. He's a 36-year-old person who uses heroin, also with some cocaine use. He's been on methadone for a couple months. He's opiate-free since he started methadone. He still tests positive for cocaine, and he says, hey, don't worry, I'm just using a small amount on the weekends. I get together, on Saturday night with my buddies, and we do a line or two. So is he a candidate for take-home doses? So generally, take-home doses are tied to clinical stability. So they need to be on a stable dose of methadone. There's no problematic drug or alcohol use. And I think he's trying to give us a sense that it's not problematic. Other things, stable housing, ability to safely store the medication. This next slide shows a table of problematic use versus non-problematic use. Now, it might be up to the individual physician. What I say to somebody who tells me, hey, don't worry, I just use a small amount of cocaine on the weekend, and usually cocaine only lasts 3 or 4 days in a urine test, but I do find if you have chronic users, it tends to last a longer time because you're testing a cocaine metabolite. So if you read a book, it'll say 3 to 4 days, but my experience has been in people who use cocaine, it lasts longer. So what I would say to him is, listen, if that's all you use, what I'd like you to do is I'd like you to stop using for a week or two, or don't use this weekend. And if you used on Saturday, then you don't use that next Saturday. By the following Thursday, that's going to be about 12 days. You'll have a couple samples that will be free of cocaine, and that shows me that you are able to control it. And if you can't stop on any weekend, then it shows that your use might be more than you're admitting. So my personal thing is I would not give him a take-home dose until he can demonstrate that he has some cocaine negative samples. Let's look at case number 3, Bill. He's a past oxycodone IV drug user. He's got an anxiety disorder. His family doctor prescribes him diazepam, 20 milligrams. He's been opiate-free for a couple months that he's been in the program. And the diazepam is still there as we expect it to be. So is he a candidate for take-home doses? So here's some guidelines from the College of Physicians and Surgeons about take-home doses while patients are being prescribed benzodiazepines. We might give him one take-home dose, but there are some circumstances that we want to make sure of are okay. Does this fellow have a medical or psychiatric diagnosis that warrants the use of benzos? Is he on a low to moderate therapeutic dose of the benzodiazepine? Because the dose is significant at 20 milligrams. Yes, I see people at 40 or 60 milligrams a day, but 20 I still feel is a bit in the high side. Does he give us consent to be able to speak to the other benzodiazepine prescriber? And this is a key point that, I want to be able to discuss or write to that other doctor. Some other points, is he prescribed and dispensed the medication in a controlled fashion, or is a doctor giving him 4 of the 5 milligram pills and a 3-month supply? So that'd be like 360 pills, which I would consider to be, too high a load on somebody to take home at any one time. Do all the other criteria meet for that? And basically what I end up usually doing is I try and either speak to the doctor who's prescribing the benzos, or if he won't give me the name of it, or if he doesn't want me to speak to him, I'll write a note to give to the patient to say, please take this to your prescriber of the benzos and write on it, are you aware that there is a potential dangerous interaction between the benzodiazepines and the methadone I'm prescribing? And are you prepared to accept responsibility for potential toxicity? And normally, the other doctor, is alerted as soon as I word things that way. And the patient, if he's motivated, may need to taper down his benzos. All I'm trying to do is just normalize me speaking to the other doctor, or, having a team approach. So at 20 milligrams, I'm a little reluctant to give this fellow take-home doses. But if I speak to the doctor and everything's reasonable and rational for why he needs it, I could make exceptions. How about another case? We'll call her Mary. 44-year-old woman, recently transferred to your methadone program, reports 2 years of samples free of unauthorized substances. So, comes to your town and sounds like a terrific, easy patient, 6 take-home doses. We do our point-of-care testing. It's positive for methadone metabolite, positive for any of the other things that we test. But let's remember that the synthetic opioids like oxycodone and fentanyl don't show up on immunoassay unless we specifically have a dip for them. So we sent it to the lab for chromatography, and she's positive for fentanyl. What should we do? And does her dose of methadone matter? So she might have been using fentanyl for the last couple of years, and the other clinic might never have known this. She might be diverting some of her methadone because she doesn't need it every day if she's using fentanyl. And I actually find in my career that the dose of methadone has been crucial in things like this, because if she is using fentanyl, we might not want to give her 6 carries. We'd give her 5, then 4, then 3. But let's say she was on 250 milligrams of methadone. Well, let's say she's not taking that 250 milligrams of methadone, and she's diverting a large part of it. What's going to happen if we give her 4 or 5 days in a row of that dose observed in the pharmacy? We may be causing some toxicity there. And I realized this sort of early in my methadone career, that some of the more problematic use was in some of the higher dose patients. So my concern is to hopefully not have people on very high doses, because you can run into problems like that if you have to give them less take-home doses. Let's take a look at alcohol use. Alcohol is an interesting drug when it comes to methadone. The acute intoxication contributes to being more sedated and toxicity, but chronic alcohol consumption can induce some enzymes and actually lower your methadone levels. And I see that quite often, where people will be sedated the day of the drinking and then feel rotten for the days after. So a very tricky drug as to what to do, and do they feel better or worse, and all that when they're using alcohol. There's the CAGE questionnaire for people who are on alcohol, and it works fairly well for alcohol, about cutting down, people annoyed, feeling guilty, do you need an eye opener in the morning? This is an old questionnaire, but it does still work fairly well. There are alcohol use disorder criteria on the DSM-5, and there are other scales to ask people. I'm not going to go through every scale. I did want to spend a few minutes on some of the medications. Those of you who are in Ontario listening to this, the first 2 medications I'm going to talk about are now covered on limited use. So naltrexone, and naltrexone's an opioid blocker. Let's not give this in someone who is currently taking opioids. We will put them in withdrawal. So if someone has an alcohol use disorder and is not on opiates, naltrexone can work very well. There's something called the Sinclair Method, where basically we don't have people take the naltrexone every day, but we have them take it on the days that they know they're going to drink. And this will make the drinking less enjoyable and lead to this kind of pharmacologic extinction where they start associating the alcohol with not causing the enjoyment or euphoria. Now, if someone's not interested in quitting, they just won't take the naltrexone and they'll take more alcohol. But if they are motivated, or if they have a family member or friend who's going to give it to them or help them through it, I find this can work very well. It works much better if you have lots of psychotherapy and counseling. So some of you who may have come across my naltrexone scripts actually say on it, 25 to 50 milligrams daily as directed and or as needed. And then I usually call the pharmacist and I say that they have a counselor, and the counselor is going to be talking through them when to take it. So a lot of times someone at the pharmacy will feel, well, it's better to take it every day. And that is okay for some people. But again, the Sinclair Method does it where we take it on, the patients take it on their drinking days. Another drug that's now covered on limited use, and at the time of this recording is not available and it's on back order. Hopefully by the time you're listening to this, it's going to be back in supply, and that's acamprosate. It's a glutamate antagonist, and it helps the brain with that subacute withdrawal symptoms of anxiety and just generally not feeling well. Tested to work the best in people who are able to quit alcohol for about 5 days and get through the withdrawal. So generally not used in people who haven't quit drinking yet. And again, covered on limited use, but at the time of this recording is not available. Other medications that I'm just going to briefly touch on, disulfiram, and that is not available in a pill form. You have to be a compounding pharmacist to do it now. And basically, if people take it, they get sick, and if they drink alcohol, they get sick if they drink alcohol, and they know that. So it's aversion therapy. My personal opinion is that one of the hallmarks of addiction is continuing to use despite harm. So I am wary about this, because if people are still going to drink, I don't like causing harm. I don't want them to feel sick. I want them to feel less enjoyment, but not necessarily sick. There are some small studies on drugs like topiramate, baclofen, gabapentin being helpful in people with alcohol use disorder. And I've certainly written a lot more gabapentin in the last couple of years for alcohol use disorder than I did in the 10 years combined previously. Cocaine use. There are some studies that show that as people get into a methadone program and they're learning good, healthy habits, that if they're using cocaine, that may settle down too if they're motivated to improve their life. But keep in mind, there is no specific medication that's been shown in lots of studies and good to treat cocaine use. There's no cocodone, as I say. Benzodiazepine use with methadone is a high risk of overdose. We treat them hopefully with a slow taper. I think it's important. There's a large Venn diagram of people who use opiates and benzodiazepines. It's important to let them know that there's early dementia, there's early falls and fractures, early death rate, all these sort of things. And again, I call that providing informed consent, because I can almost guarantee that years ago when they were put on a benzo and an opiate, that no one told them that this is a dangerous combination. That being said, if someone's on doses of both and we can make an attempt to taper, but it's very difficult to get somebody 100% off benzos. But the lower we can get them, probably the better things will be for that. Here's a summary of taking a look at the pharmacist's role. Pharmacists and the pharmacy play a key role in all avenues of healthcare, but I really think in the opiate use disorder world, they play a bigger role than in the other categories. You might be seeing the patient every day. You're able to pick up behavior changes or physical. See, they smell, they are coming in with other people that might be bad influences. Educating them, giving them a daily positive influence. If they're getting their medications, and you might know about different doctors prescribing. And in Ontario, you'll pick that up before we will with a monitoring system. Our monitoring system's far from perfect. And you'll alert us to double doctoring, safety of medications that different doctors may be prescribing. So really the role of the pharmacy is key in the world of opiate use disorder. Here's a list of resources, and feel free to look these things up. And it's always possible in a couple years, if you're watching this, there might be new resources as well. Now for the second part of our presentation, we're going to talk about some psychiatric comorbidities that can exist in our people on medically assisted treatment. Here's our learning objectives, and what I want to stress while you're reading this is I'm not a psychiatrist. So I'm a family doctor who developed an expertise in opiate use disorder and treating other addictions. And through that, there's an awful lot of people that have psychiatric comorbidities. So I've developed some expertise, but I still may say things that a psychiatrist may say that I lack, the extreme expertise in that. But that's fine, because I think for the purposes of what you need to know now, I'm hopefully going to be able to translate that knowledge to you in a good and effective way. So taking a look at some concurrent psychiatric disorders, here's our goals. You'll hear some different terminology, and as you do some research in this, some things may say co-occurring, some things may say concurrent. You'll hear dual diagnosis, dual disorders. They may mean slightly different things to slightly different people, but for the sake of today, we're going to use them relatively interchangeably on people who have both a substance use disorder and some sort of mental illness issues. Let's take a look at a case. This is a 25-year-old woman who's on methadone, 100 milligrams, full carries, couple years. Recently, though, she's been a lot more disruptive, talkative in the pharmacy. No other medications known to you. And I just want you to think about what some of the things that could be going on that could be causing her to be more disruptive and talkative in the pharmacy, maybe a little bit more belligerent, hard to say. So we'll come back to her much later in the presentation, but I'd like to show this early to put a picture in your mind and get you starting to think of some of our patients that we see come in. There's 4 ways to look at a combined model of having 2 different diagnoses. One, and I'll show a slide on each of these later, the common factor model, where whatever